So I am now recording this webinar. So as with normal webinars, your mics and your cameras are turned off, but we are really grateful for any questions that you may have. And I'm sure some of you have come already with a few questions. So there's a Q&A box at the very bottom. So please feel free to type in any questions you have in that, and we'll get back to you at the end of the session or throughout the session with answers to your questions. I'll be sending the recording out to you all, anyone who signed up by the end of the session, the end of the day, sorry. So if anyone's missed it, or if you want to rewatch it or share it with someone, you'll get that link in your inboxes and the email address that you signed up with a webinar for at the end of the day. I just want to introduce you and thank Chris Russell and Dr. Rebecca Kozor for coming along today and volunteering their time to run this webinar with us and share some of the really great information that they've got with all of our wonderful Heart Health Club members. Chris Russell is one of our wonderful ambassadors who has been working with us for many years now, and among many things that he does, he hosts these webinars for us, and he's so wonderful at it, and we're so incredibly grateful, Chris. So thank you so much.
No worries at all.
And Dr. Rebecca Kozor is a practicing cardiologist at Royal North Shore Hospital and at North Shore Private Hospital. In addition to this, she's a senior lecturer at the University of Sydney for the Faculty of Medicine and Health, and is also a co-director at the University of Sydney Cardiovascular Magnetic Resonance Group. And on top of that, she's an honorary medical director for Heart Research Australia. So she's an incredibly busy woman, and we're so thankful and grateful to you, Rebecca, for taking the time to chat with us today. So I don't want to waste any more of your time. I'll pass over to you guys so you can get started. So thanks so much everyone for attending, and I hope you've all got your cup of tea with you. We've all got our tea, so we're all ready to go. So thanks so much, guys.
Thanks, Jenny, and fantastic to be doing another one of these. These are an exciting exploration of the world of the cardiac brainiac, I always say, and I always look forward to them tremendously. And Rebecca, talking to you today is a great privilege for all of us, I must say.
Yeah.
Tell me, what is a heart attack? Just tell us in simple terms what happens when you have a heart attack.
So a heart attack is when the arteries that supply the heart, which sit on top of the heart and penetrate into the heart, when one of them or a few of them block off and stop the blood flow to the heart muscle, the heart muscle then begins to die. And that dying of the heart muscle is what we call a heart attack. The medical term is myocardial infarction. And that infarction means death of the heart muscles. Yeah.
And what's the difference between, I mean, I know you guys all love these big long words, but what's the difference between a myocardial infarction and a cardiac arrest?
Yeah, that's a good question. They're often intertwined, but they're very different things. So I've mentioned what myocardial infarction is. That's the heart attack, the blocked artery. A cardiac arrest is when the heart stops beating. Essentially, the body doesn't have a beating heart, and so the body is dead. The stopping of the heart beating, the actual cardiac arrest, causes the whole circulatory system to collapse and to stop. But there are multiple causes of a cardiac arrest. One of those causes is a myocardial infarction. If the heart attack goes on very extensively, the heart muscle can stop. But there are other causes as well, and there's a list of them. So to answer your question, you know, these two words, these two terminologies, myocardial infarction, cardiac arrest, different things, and they should not be thought of as the same.
So given they are different things, and we all hear about all these symptoms of when you're having a heart attack, but how do you know whether you're having an infarction or a cardiac arrest, or doesn't it matter?
Well, let's talk about myocardial infarction. So a heart attack, how do you know? So the typical symptoms of a heart attack are chest pain in the middle of the chest, heaviness, pressure in the chest, And sometimes that pain can radiate up into the jaw, up into the neck and into the jaw, down the arms, maybe just one arm. The classic is just down the left arm, but can also go down the right arm as well. And people typically can feel nauseous with it, sweaty, and feel generally unwell. So they're the typical symptoms, but unfortunately not everybody gets the typical symptoms.
Yeah, I didn't have any of that. I had a big heart attack in 2004 when I fell into some very cold water. Didn't have any of that. No pins and needles, no pain, nothing going down my arms. I just felt very kind of woozy, almost like I just not quite sure what was going on. And my wife tells me I look grey, but none of those things.
Yeah, so people can feel different symptoms as well, and dizziness, lightheadedness can be one of those symptoms. Maybe just a little bit of discomfort or no discomfort. Breathlessness can be one. Suddenly someone's quite breathless when they're doing their daily activities. Pain in the back. These symptoms that often just by themselves don't point to the heart at all. So it can be really difficult to identify if somebody is having a heart attack. And that's part of the reason why people present later than expected to a hospital or to a doctor, because they're not sure. And it's completely understandable that they're not sure, because if you just thought, oh, I'm just feeling a little bit off today, a little bit dizzy, it's not in the forefront of everybody's mind, I'm having a heart attack. And often it's the intuition of somebody that you think something's not right here. This is different and I feel really quite horrible. I should be getting checked out. Or like you, Chris, a bystander, your wife, or maybe for other people, a different person flags that, oh, you don't look well, let's get some help.
Yes,
yeah,
well,
I mean, my wife was a
gut
nurse.
instinct as well.
Yeah.
My wife was a nurse, and I think if she hadn't been there and identified what was happening, and she rang 000 from the boat, I wouldn't be talking to you today, I don't think.
That's very possible.
Tsunami, which we'll come to. What about a cardiac arrest, Rebecca?
So cardiac arrest, as I mentioned, is when your heart stops. So you will not know about it, because you'll be, if you're not already on the floor, you'll collapse to the floor, and you'll have no recollection of what's going on. So that is where bystanders will recognize that you've collapsed, and the need to call, you'd be unresponsive and not breathing probably, and someone would need to call a 000 straight away. That's more obvious. That's definitely more obvious.
But you don't notice anything prior to that happening? You wouldn't suddenly begin to feel a bit dizzy or something just before it?
Yeah, you can, absolutely. But often when people wake up from their cardiac arrest, if they survive, if they're the lucky person that survives, the brain doesn't always remember. So even if you had felt something, you may not remember. But the symptoms can come beforehand.
And Rebecca, what about men and women? Are there differences in the symptoms for men and women? Do women feel the same things, or are they different again?
So this is a really good question for all the listeners out there, all the viewers out there. This is something that I always try and stress, that there are differences between men and women. Women typically don't get the typical symptoms. So a woman is more likely to get just a bit of breathlessness, the dizziness, feeling not quite well that day, or pain somewhere else, not that classic pain. Having said that, they do experience the classic pain. It's not that women don't experience that, but they're more likely to experience these other more vague symptoms, which makes it really difficult to identify. So for that reason, women may dismiss their symptoms, get on with doing other things until it's really quite dramatic, and oh, I'm very unwell, I need to go to hospital, or however they whatever first point of medical contact they go to. And the reason why women and men get different symptoms is really quite complicated, and we as in the medical community don't quite fully understand why. There are hormonal reasons, there are psychosocial reasons, and probably reasons that we're not aware of. And there's a huge amount of research that's going into this. Why are there these differences between men and women?
So I always thought that men, big macho, nothing wrong with me sort of people, are more likely to miss symptoms of an impending heart attack than women, who are more pragmatic and saying, I don't feel so good, I better sort it. But are you telling me that women are actually more likely to miss symptoms, or men?
So men do, this is from my own experience, men do ignore symptoms and think, oh, I'm going to be fine. But when it's those classic symptoms, they don't ignore them in general. Whereas women, when they have the classic symptoms, they go and get medical care. But because they're getting all of these unusual non-classic symptoms, that's when it's really difficult. So, there's a bit of both in males and females as well, I would say.
So, Rebecca, earlier this year, I interviewed for my podcast series, AgriMinders, I interviewed a guy called Greg Mullins, who used to also be an ambassador for Heart Research Australia, and probably still is, but he was one of the fittest blokes of my age that I know. I look upon him with envy. I mean, he was the Commissioner for Fire and Rescue, New South Wales Fire and Rescue. He prided himself on being as fit as all the young men that he was over in the rescue service. Fights fires, went all over the world, fighting forest fires, whatever, had a heart attack, didn't smoke, didn't have blood pressure that he knew. Well, he said he didn't have blood pressure, didn't have cholesterol problems. Being in fire and rescue, they gave them all these checks all the time. Didn't suffer from diabetes. All those, they're the classic sort of pre-existing conditions. Suddenly has this massive heart attack. Why do people who are so fit have heart attacks, when they don't have any of those conditions, and men and women?
Yeah, that's a good question. So it is very possible to have a heart attack when you don't have the risk factors that you've mentioned. And maybe we'll talk about risk factors, in a minute, but studies have shown, and one study, at least from our local health district, 15 up to 25% of heart attack patients don't have any of those traditional risk factors, but they're still getting a heart attack. And we don't know the answer to that. We don't know what is causing a heart attack in those patients, or what the risks were to those particular patients. And there's a lot of research going on around the world, and in my hospital and university where I work, there's certainly a big focus on that. Why is it that these people have a heart attack? How would they have known otherwise? Yeah. How could they have protected themselves? Well, yeah, we don't have the answers. It's a frustration of medicine that we don't have the answers to everything, unfortunately.
Is there some test, though, that you could do, even in the absence of all those conditions, that would look for an enzyme or look for a genetic flaw or something that would say, well, yep, you can be as fit as you like, but you're 80% sure you're going to have a problem with your arteries hardening or something?
No, so there's not a test. That is where some research is focusing on. Wouldn't it be great if you could have a test that would identify you as at an increased risk, so that you could potentially modify your lifestyle or in other ways to help protect yourself. But at the moment we don't have a test. you know, like in the cancer kind of field, they have genetic tests that can pick up genetic changes that can put people at risk of particular cancers. We don't have that in the cardiovascular field. We just have the traditional risk factors that we know about. And I guess this is a time to talk about those, if I may.
Go for it.
So the traditional risk factors for a heart attack are, you can divide them into those that we can modify or that we can change and address, and those that we can't. So the risk factors that we can't change are genetics, or the predisposition that may have come from our ancestry. You know, my mother might have had a heart attack at a young age, or my father, people close to us in the family tree. If that puts an individual at increased risk, if we've got someone in the family that's had a heart attack at an earlier age, like less than 65. So then there are the factors that we can alter, or we can try to address with either lifestyle or medications. One is high cholesterol or lipid problems. Another one is diabetes. Smoking is a big one. Obesity and being sedentary goes in with that as well, and high blood pressure. They're the major ones for both sexes. Females also have some very unique risk factors as well, and this is such as high blood pressure and high sugars or diabetes during pregnancy. That's called gestational diabetes or gestational hypertension. And women can also have problems in their childbirth, something called preeclampsia, that can put them at increased risk, not during the time, but 10, 20, 30 years down the track, can increase their risk as well. So that's particular to women. But going back to these treatable or modifiable risk factors, there's a few of them, as I've mentioned, and we can address those with if an individual knows their numbers, knows what their blood pressure is, what their cholesterol is, that's what we can target before a heart attack, and obviously we target after a heart attack as well.
And it doesn't matter whether you get the low cholesterol via you just don't have high cholesterol, or whether you take some sort of drug, a statin, to lower the cholesterol. Cholesterol's cholesterol, and if you can keep it low, that's better. Is that the story?
Yeah, that's right. If you're talking about somebody that hasn't had a heart attack, trying to prevent a heart attack, getting a cholesterol as low as possible, and the Australian government mandate that the first line of treatment is lifestyle changes. So changing your diet, exercising and losing weight can dramatically affect somebody's cholesterol level. So that's our number one goal. And if that can't be achieved, if that lowering cannot be achieved with really good lifestyle measures, then that's when we would then consider prescribing medications. You mentioned statin is one of them. That's probably our first line, our most common medication, anti-cholesterol medication that we have. For patients that have had a heart attack already or have known coronary disease, that's slightly different. So we absolutely still encourage lifestyle changes of losing weight and altering our diet, but it's more important for those individuals to take a statin regardless of what their cholesterol level is, because the statins offer such a benefit to the heart in trying to prevent future heart attacks.
So I've got mates who just have got a thing about saying, oh, but I'm achieving my life without having any drugs. But if you've got high cholesterol, I mean, surely you need to take those drugs and keep that cholesterol down, and not have some sort of shame factor about the fact you're doing it with drugs if that's what you need.
Yeah, so it gets quite complicated, and it's really an individual decision between an individual and their cardiologist or their GP, whoever's prescribing it. But statins are so important to get the cholesterol down. And many people don't want to take medications. I understand that. But if the need is there and the side effects, because we always have to think about side effects as well. If an individual doesn't have any side effects, then these tablets are really great. As soon as we start talking about side effects, though, that's when you have to weigh up the risks and the benefits. And unfortunately, statins do have a long list of side effects that can affect people in different ways.
So, I mean, I remember my cardiologist saying that he keeps my cholesterol down at around 3.4 or very low. And he said there is some evidence that you can actually mine the plaques back out of your arteries with low cholesterol. Has there been much more work done on that?
So there's not strong evidence to suggest that once cholesterol is in the arteries, it's really there. We never see it completely going. So if somebody has a near blockage or a partial blockage, it's never really going to go away with the medications. But there has been evidence that there can be some regression, or more importantly, it's stabilization. So the actual vessel wall, the arterial wall, where the cholesterol plaque is in, that cholesterol plaque is like jelly in a way, and almost like a pimple, it can pop. And if it pops, the cholesterol that comes out is sticky to blood, and blood sticks over the top, and that in itself can block off an artery and cause a heart attack or a myocardial infarction. So one way that statins work is that they stabilize that cholesterol and jelliness to try to prevent that plaque, that area, from popping.
Right.
A bit gross, really, isn't it?
It's a great explanation, though. So
yeah. So there are definite, benefits of taking these drugs.
So Rebecca, in your last time, I think that we had a chat at an event like this. You were still doing your PhD on the use of MRIs in being able to diagnose and look for things that are going to cause a heart attack.
Yep.
Where is that technology at? Are we able to go in and for them to look at a much more detailed way without going through echo stress tests and all the rest of it and say, wow, there are some beginnings of problems there?
So MRI, just to explain to our viewers, is a medical imaging test that's made up of a magnetic field. It's a tunnel, and patients go in and out of the tunnel. It's usually quite a long scan, and what we can use the MRI scan for our heart is to look at if anybody's had a heart attack before. We can look for scarring in the heart. We can also do a stress test with the patient lying down. So it's not a treadmill stress test like the traditional kind of treadmill. We mimic a stress test by injecting a special medication, a stress medication called adenosine, and it increases heart rate and contractility of the heart to kind of mimic the stress. And using that, we can assess to see if there are any significant blockages that cause the blood flow to the heart to reduce during that stress test. And it's not just, this is the amazing thing, the big arteries that cause the heart attack, but it's also the really, really small arteries that we can indirectly look at the blood flow. That's called microvascular dysfunction. So the micro vessels that we can look at. And so it's been well proven that heart attacks cause problems in people, changes people's overall prognosis, and there's a lot of morbidity and mortality related to it. But these micro vessels as well have also been shown to have poor outcomes. And so with the MRI scanner, we can assess that blood flow. It's really quite amazing. Unfortunately, in Australia, the MRI scans are expensive to patients because Medicare as yet don't recognize the health economic benefits of MRI scan to the heart in Australia, despite the international evidence around the world. So in the UK, in the US, in Europe, they use this technique to assess patients' hearts. In Australia, there hasn't been good, solid health economic data to support its use. So Medicare doesn't reimburse it. So if I, as a cardiologist, say to you, Chris, you need an MRI scan of your heart, I want to look at your microvessels, unfortunately, you're going to have to pay or not have the test. That's a really hard decision that I have as a clinician with patients, you know, to say, I think the best test is an MRI scan, but, you know, maybe you can't afford that. That's really tough. And it's actually my research that I do on MRI is not only in the technical aspects of looking at the microvessels, but also in the health economic side as well, to try to lobby the government to support this amazing test.
You scare the heck out of me when you start talking about bureaucrats with purse strings deciding on what my health's going to be in the future. I hear it from my son as well, who's the intensive care nurse. And, you know, people start making Apache scores and things and deciding whether you're worth saving or not. That scares the heck out of me, I must say.
Yeah,
But
I mean, with everything in healthcare, it's you know, there's an individual out there that you're treating, but there's the broader health economic burden, as I might say, to the Australian healthcare system. And as a clinician, you need to kind of weigh up both of those things.
Mm. So we've talked a lot about finding out if you've got one. Just one little quick point. You've also done a lot of study of very rare genetic diseases, nothing to do with all those factors, things like Fabry disease and other things. Is there any way that as a baby or even an unborn baby, or certainly as an adult, that you can have a look at your genes and they can say, wow, I think you're going to get this disease in terms of a genetic disease?
So there are lots of genetic diseases that can affect the heart, and there are specific genetic tests. We don't offer them during birth or as a baby's born or childhood. They're usually later in life when two scenarios occur. One is if there's a family history, mum or dad, cousins start to display a problem, and the suspicion is that there's a family that have a genetic problem, then people get tested, but only under the supervision, the strict supervision of clinicians who know what they're dealing with and they're talking about in terms of genetic heart disease. And the other scenario is when somebody, an individual, comes in with a particular problem that really sounds like a genetic heart disease problem. They then are maybe the index case, the first case of the family, and they can get tested as well. But again, only under the strict supervision of a clinician who knows about genetic heart disease and knows the consequences of diagnosing a genetic disease, because it can be quite devastating, not only to the individual, but to the broader family as well. And that's where genetic counselors are really important to get involved with. Yeah. And
you can't, if you find you've got that, we're not at the stage yet where we can either modify or remove that gene or do anything like that. That's ethically, we just don't do that sort of thing, do we?
We don't, but there are studies that certainly look at that. It's a particular part of research that is going on in the cardiovascular field around the world. Maybe one day, one day. Yeah.
Well, we've come a long way in agriculture. Why not hearts technology as well? Can I move on to what people should do about heart attacks? So if you think someone's is having a heart attack near you, what should you do about it? And probably a cardiac arrest is different because they've just fallen on the floor. But I'm thinking now someone's saying, oh, I feel like I've got indigestion or whatever.
If the suspicion is a heart attack, and have a low suspicion for it, be quite vigilant. The bystanders surrounding people, or the individual themselves, if they're not surrounded by people, should call 000, call for an ambulance. Don't be afraid or don't be embarrassed that you're using a service. That's what it's there for, because calling an ambulance and getting to hospital saves lives. If you delay getting to medical care, there are worse outcomes for people who are actually having a heart attack. So it's always best to, number one is to call 000.
So Heart Research Australia has been involved in some very significant changes in the way we've run that system. One of them, which I think, in my belief, saved my life, was the ATAMI system. Now, you caught me out before using an acronym without explaining. That's a first for me. Normally people don't do that, so thank you. But ATAMI stands for early triage. After you talked about before, a myocardial infarction. And that meant that the AMBO could talk directly to you at the hospital rather than have to go through some complicated nearest hospital thing. How significant has that been in being able to get people and having heart attacks fixed?
Yeah, well, let's just go back in time. So years ago, if somebody thought they were having a heart attack and they call 000, ambulance comes to the house or wherever they are, they assess them and they think, oh yeah, this looks like a heart attack. Let's take them to the nearest hospital. Then they drive to the nearest hospital. If that nearest hospital happens to be a small community hospital, whether it's in a big city or remote rural areas, if it's a small hospital that doesn't have the facilities to deal with a heart attack, they then go to that hospital. They're then looked at by a doctor there, and that doctor will say, oh yes, this is a heart attack. Let's call the major hospital, communicate with them. We've got this heart attack patient here. All this, the time is ticking. Every minute is going over. Then they bundle that patient up, take that patient to the other hospital. That just so many minutes can have gone past. We're talking even hours have gone past between the time that that person originally felt the symptom and when they finally get their treatment. And that is a delay. So what this external triage means is that the external triage is the ambulance. So when the ambulance arrives to the patient for the first time, first medical contact, that ambulance has the ability to send the ECG, which is the heart tracing that shows the acute heart attack. They have the ability to transmit electronically that ECG to the major center where the heart attack patients go to, and that they say, yep, that's a heart attack, go directly there. Lights and sirens go on. They bypass the smaller community hospitals and go straight to the major center. And so we then are gaining time compared to that previous kind of pathway. And the patients don't even go in through the emergency department. So there's no emergency doctor there having a look at them. They just hit the hospital, arrive at the hospital and go straight to what we call the cath lab or the angiography lab, which is probably what happened to you, Chris, where you go straight into the procedure center and have the angiogram.
Yeah, I'll come to that. My question is, why aren't the ambulance officers able to look at that ECG and say, yep, that's a heart attack, let's go to the hospital?
So they do. They're the ones that have to recognize it first. So they're very well trained to recognize the ECG, but it's the heart attack center that need to approve the actual system of bringing the patient in. Number one, just so that they say, yes, you are correct, but also two, so they can facilitate their own workforce to be prepared for when that patient comes in, because the patient could be really, really unwell and need extra support, or, there's a range of things that can go on. So there needs to be that communication there. And, we talk about Heart Research Australia being part of the initiation of that in Sydney, Australia. But this now is almost a standard of care around the world, that patients have or that there's this ability to transmit ECGs and patients go straight to the cath lab rather than having to go to regional hospitals or go in through emergency department and other doctors.
I think I saw somewhere the other day that the death rate from heart attack prior to, say, 2000 in Sydney was around about 35%. And since Itami, if you live within 40 minutes of North Shore Hospital, it's down to 2%. Are those statistics right?
I don't know the actual statistics, but there's definitely been a reduction in the death rate and the complication rate of heart attacks with the introduction, with the ability to be able to treat patients faster. Because as I said, if you think about the myocardial infarction, the heart attack, the blocking of the artery, the longer the artery is blocked, the longer the time is that the heart is starved of essential oxygen, and the greater the area of damage to the heart. And once heart muscle cells die, they cannot be regenerated. So if you're waiting longer and longer and longer to have that blood vessel opened, more and more heart muscle cells die, and that dying of the heart muscle cell causes scarring, and scarring can cause a lot of problems in the heart.
Well, I remember them talking about the Packer Whacker when Kerry Packer put defibrillators in all the ambulances, but it sounds like Itami, put in by Heart Research Australia, was probably as significant in getting that death rate down, compared even with that.
Yeah, they're both very vital services. The defibrillator is once somebody has had a cardiac arrest. So I go back to what we were talking about at the beginning, when the heart muscle has stopped, when the rhythm of the heart has stopped, it can be shocked back into a normal rhythm, and that's what the defibrillators or the Packer Whackers do.
Yeah.
Yeah.
So once you get to the hospital, in my case, I arrived at the hospital, the doctors were already waiting for me at Royal North Shore, and they said, there are two things that could happen here. You'll either have a bypass operation, or another thing which I know Heart Research Australia put a lot of money into early on, called another acronym of SALAMI, which I think stands for stenting as an alternative to, they call it lysic therapy, but I mean dissolving the clots. Instead of that, you put a stent in, which is obviously sounds simpler. How do doctors decide whether they're going to cut me open and graft a new artery, or whether they're going to actually use a stent, which is like a bit of reinforcing to shove in your artery?
So in general, the decision is done, first of all, at the time of the heart attack, when a blocked artery is identified. So if there's just one blocked artery, typically the mainstay of treatment is a stent. So that stent goes into that blockage, opens it up, and restores the blood flow. However, if there are multiple lesions or blockages, let's say three is a good number, then the advice is usually to have bypass surgery. And the reason being is because clinical trials, so all research that has been done over time, has shown better outcomes for people who are having bypass surgery compared to stenting. The more arteries they have, or the more complicated these blockages are, particularly in diabetics. But there is more, I guess, having said that too, the technology that has driven stenting over time has really accelerated. There's been so much research into stents that the benefits of stents are improving with time as technology improves. And so there's always these head-to-head trials of what's better, stenting versus bypass surgery. But in general, the more blockages, we go down the bypass surgery route. But every individual case is, I guess, looked at individually. What's the benefit of the particular patient that's in front of us?
Well, I must say I had a stent, 16, 17 years ago now, and I touch wood, I haven't had any issues at all. It seems to work well, and it was an unmedicated stent too. So stenting obviously can work well in some cases, and I've had a relatively normal life, and that's a wonderful technology. All of these fixes we've been talking about, Rebecca, when they come along, I interviewed the other day about these new patches with stem cells that can actually regrow heart tissue. But as soon as you hear about them, you think, what a miracle. And yet the next statement is, but it'll probably be 10 years till we see it. Now, a year ago, we'd never heard, well, just over a year ago, we'd never heard of COVID. And yet within 6 months, we had a vaccine, and within another 3 months, it was approved. How does that happen so quickly? And yet some of these other technologies, which are life-saving for probably, I mean, double the number of people die of heart attacks in Australia than would have died of COVID if we'd had the same statistics as America. But we still don't seem to have any sense of urgency amongst the bureaucrats in getting these things approved. Why is that?
Well, this is, it's complicated, but I think COVID's a nice example. So COVID-19, was not around before December 2019, I think it was. And then it hit the world. So that's different from cardiovascular disease. Society has grown with cardiovascular disease over the decades. So we have two different types of problems. We have a chronic problem, one that's been, there brewing for ages, that takes a lot of lives, as you said. And then the difference to that with COVID is that there's suddenly this new disease that is threatening the entire world at the same time. Whereas cardiovascular, that the scenario is a little bit different. And I think
it tells me that where there's a will, there's a way.
Exactly. So the point is that with COVID-19, the solution was one thing, and that was a vaccine. There is no one solution to cardiovascular disease. There are multiple different components. It's very complex, and there are great technologies out there, like you said, that just are taking time. But the efforts, it's all about the effort and the world stage that grabbed COVID-19, and the whole world was fixated on finding this solution to a worldwide problem, whereas cardiovascular disease is not viewed the same. So it's complicated. There are political and geographical issues, but in general, like you said, in any field of medicine, technology takes a long time to get into clinical practice. From the day that the scientist who's in the lab discovers something, it then needs to go to the next stage, which is doing some clinical trials, and then goes to the next stage and the next stage, and we've got to have health economic data, and we've got to have this, we've got to have that, and eventually we'll see it. And how that time period changes slightly for different interventions, and is obviously very quick for COVID-19. So it's definitely doable on a worldwide stage, but unfortunately with cardiovascular disease, we don't have that worldwide stage. And yeah.
Well, Rebecca, can I just finish with two questions for you then? As one of the world's leading cardiologists, first of all, what has been the most significant advance you've seen in treatment of heart attack over the last 20 years? And, we have a wonderful bequest program at Heart Research Australia, and many small bequests make up a lot of money, which can make a big difference. But let's say Bill Gates turned up with $50 million and dropped it in your lap and said, you decide what to put the money in that's going to give the biggest return in solving this problem. What would you do? So those two questions.
Okay, so I'll answer both of those, and just for the viewers, this is my particular opinion. Everybody would probably have different opinions on this, but to answer your first question about the major advances, I think it's what we've been talking about is heart attack treatment. getting patients early to hospital and giving them a stent. That has kept people alive. Stent technology has improved, and also the knowledge that getting patients early to hospital, early to medical care, saves lives. That's a simple intervention. It's not a technical device or anything. And so we recognize now these benefits. And what was your other question? I just
the other question is, someone dropped 50 million bucks in your lap. Yeah.
Oh, well, I think, in my opinion, that preventing cardiovascular disease needs to be more of a focus worldwide. So we have technologies and medications to help people who've had heart attacks and particular cardiovascular disease. But in my opinion, the factors that affect and put people at risk of cardiovascular disease, like obesity, high blood pressure, high cholesterol, smoking, are just growing and growing. We know that people are getting more and more obese, morbidly obese, every decade around the world. If we could put that money into preventing people ruining their lifestyles, I think we would have a great chance of reducing the incidence of cardiovascular disease.
And what about fixing it once it's happened?
Yeah, that is obviously very important as well. But you asked me what I would put my money
into.
Yeah,
that's where you would put your money into, the prevention rather than the fixing afterwards, probably. Yeah. All right, well, look, Rebecca, that's been a fascinating thing. I mean, as I've said many times in this forum, one of the really frustrating things for me is to see how much time people like you have to put into actually putting the money together to make all this stuff a reality. And the people who are watching today are all people who we're all so grateful for. Me, as someone who's had a heart attack, despite not having any of those preconditioning conditions, I'm grateful having met my grandchildren because of the money that's been put in by people before into this. And it's everyone that's watching today, all we can say is how appreciative we are that they're putting their money in, saving you wasting more time having to plow through bureaucracy to get it out of the government. And it's wonderful to hear from you just what progress you're making. So it's been a fantastic experience. I think you've really cleared our minds on what causes, what we can do about it, and where we're going in the future. So I really appreciate your time today, Jenny, and thank you very much, Jenny, for putting this together for everyone.
No worries at all. I've just got a few questions that have come in from the people who've been watching this. So if you've got a few more seconds, Rebecca, I'll just take you through those. So the first one was from Brian. He asked, when people with no risk factors have a heart attack, what is it that's blocked their artery?
So the mechanism of the blocked artery is still the same, that the artery itself can have a blood clot in it. But the build up to that particular scenario is not clear. So they don't necessarily have the cholesterol and the high blood pressure or the family history that have predisposed it. But the heart attack itself is the same.
And from Judy, we had a question. Is there any evidence, which is actually a really good question, I've had this one myself, is there any evidence that taking fish oil and or low dose aspirin can reduce the risk of heart attacks? So I know on fish oil packets, they actually advertise that it can reduce, improve cardiovascular health. And I've always wondered how accurate that was.
So fish oil, no, is my answer to that. It doesn't prevent heart attacks. Aspirin does though. So low dose, 100 milligrams, it does. But it is not for everybody because there are side effects of aspirin. Aspirin thins the blood, and so there can be bleeding risks associated with it. So the advice to everybody is go, and if you're concerned, go and get a heart health check by your GP as a start. know what your cholesterol is, know what your blood pressure, get checked for diabetes, get checked for your cholesterol, and know your family history.
Yeah. Yeah, no,
So,
numbers.
Rebecca, on that question, does fish oil have any benefit at all in helping with lowering cholesterol? I know it doesn't prevent heart attack, you're saying. What about lowering cholesterol?
Yeah, it does have anti-cholesterol effects. You've got to take it in quite a lot, though, and it probably depends on who you talk to. It's not my area of expertise, and I don't prescribe it, but there are certain scenarios where somebody may need to take it. Okay. But it's not a general let's go to the vitamin store and pick it up and take it to prevent a heart attack in the future.
Yeah. So I have two questions that are quite similar. So one of them is from Susan, whose husband sadly passed away 2 years ago of bilateral pneumonia after he had a silent heart attack, which they'd never heard of and didn't know anything of. He didn't suffer any pain. He was just increasingly tired. Sometimes he had an ECG 5 months before. And I know we've also got another member of the Heart Health Club who has spoken to me before about having had a silent heart attack. So, and then we had one other question. It said, is it possible to have a heart attack without knowing it, as in a mild heart attack, which is from Jeanette? So they're both quite similar, that I guess, yes, you can have a heart attack without knowing it being a silent heart attack.
You can, because there's this range of symptoms. Yeah. And unfortunately, people do have heart attacks without knowing, or it might not be that they didn't have any symptoms. It's just that they had very unusual symptoms that have been dismissed or were very mild and not really recognized. But then they have had a heart attack, and then that can cause the same problems that a heart attack that is recognized. And people can become quite unwell with that. And the next question is probably, so should everybody be getting checked for silent heart attacks?
And I think also along with the silent heart attack, as well as, you say that with women, the symptoms can be quite varied and, not the typical symptoms. At what point, most people will have, they'll be, always exhausted and so on. At what point do you treat it as an emergency and say, I wonder if, should I be calling 000? At what point do you, if you just, I don't want to call 000 and say, oh, wake up this morning, I'm just absolutely exhausted. They're going to be like, go to bed.
Yeah.
It's hard to.
That's a hard one. I think getting back to the intuition, if you feel that something is wrong, then go to your GP and get checked, get a heart health check. Or if your GP is unsure, they'll send you to a cardiologist. Yeah. But if you have any of the more urgent symptoms, then go to hospital.
Yeah, call 000.
Yeah.
Great. Well, they're the questions that we've got. And thank you just so much to you, Rebecca and Chris, for your taking the time to chat with us. That was so wonderful. I found that so incredibly interesting, and I'm sure everybody else did as well. And you went into so much detail and you explained it so well, Rebecca. So we're really, really grateful for that. So yeah, thank you so much for everybody who was watching. Thank you for coming along. I will be sending this in a link to you in your email addresses. So keep an eye out for that, and feel free to share it with anybody else who you think may benefit from hearing about this. And as always, listen to your body, know your symptoms, know your numbers, know what could cause a heart attack. And as Rebecca says, if you're ever in doubt, call 000 so we can get, urgent medical attention. So great. Thanks so much, guys.
Thank you.
Bye.
Bye.